Human suffering is deeply personal, abstract, and subjective. Yet modern clinical practice requires this reality to be quantified within the rigid grid of statistical measurement. This tension between relational therapy and objective data might feel like a modern bureaucratic invention, but the earliest pioneers of counseling never saw a dividing line between their theories and rigorous scientific inquiry. Early psychoanalytic theory was built as a systematic attempt to observe, record, and map the mechanics of the mind. Strict behavioral empiricists approached the same goal by measuring observable actions and mapping exact responses to specific stimuli. Even the humanistic pioneers who championed person-centered empathy grounded their core conditions of therapy in rigorous observational research. Over time, however, the field focused heavily on technique. The profession fractured into theoretical silos, often prioritizing loyalty to a specific approach over measuring the common factors that actually drive successful outcomes across all of them. That luxury of isolation is over. In the current era of accountability, shrinking budgets, and oversight from third-party payers force modern clinics to prove that their interventions achieve their goals. This is a professional requirement. The ACA Code of Ethics and the CAC-REP 2024 standards explicitly mandate that counselors offer treatment plans holding a reasonable promise of success. For many practitioners, quantitative data can feel alien, like math intruding on a relational space. However, applied research is more accurately described as the systematic practice of clear seeing. Mastering research and program evaluation ensures a clinical intervention is actively reducing suffering, rather than merely intending to do so. Part 1 of the text, Establishing Foundations, sets the structure of our inquiry before we ever attempt to measure an outcome. The first principle of that structure is recognizing that clinical evidence is not a binary switch of true or false. It exists on a spectrum of confidence. This diagram outlines the CDC's continuum of evidence. The lowest tier contains practices supported by theory, lacking empirical trials. The middle tier features practices supported by emerging empirical research. The highest tier is reserved for well-supported, evidence-based practices, proven effective through rigorous evaluation. To elevate an intervention to that top tier, counseling borrows a continuous feedback loop of quality improvement directly from the field of public health. This cycle illustrates the CDC's 6-step framework for evaluation. It begins by engaging stakeholders and describing the program's parameters. Next, evaluators focus the design and gather credible evidence. Finally, they justify conclusions based on data and ensure lessons are shared to improve the program. This 6-step cycle allows a clinic to move from a static model to one that continuously adjusts its protocols based on actual client outcomes. Part 2, Using Research and Program Evaluation in Practice, introduces the critical concept of question design fit. The methodology you select cannot be arbitrary. The specific clinical crisis or operational threat you are facing must dictate the statistical tool you use. Consider Maria, a clinical director for an agency specializing in sexual assault survivor services. Her agency is facing a severe drop in funding alongside an expanding waitlist. She is considering imposing hard limits on the number of sessions clients can receive for the first time. Maria cannot implement this change blindly. She has an obligation to evaluate exactly how this disruption will impact a highly vulnerable population. Maria could use a measuring change with a single group design to track outcomes before and after the session limit is imposed. Simultaneously, she could deploy qualitative designs to capture the nuanced, lived experiences of the survivors navigating recovery under new constraints. Then there is Paul, a school counselor trying to launch a college readiness pilot program for first-generation students. The administration is reluctant, fearing that pulling students from regular coursework will put them behind and damage the school's already low test scores. He is granted a 1-year pilot, but its renewal is contingent entirely on proving that the program achieves its goals without causing any academic decline. Paul could select an evaluating differences between groups design. By comparing the acceptance rates of his pilot students against a control group, he can mathematically prove his intervention works safely. Without a precise question design fit, both Maria and Paul would lack the empirical leverage necessary to protect their clients and save their programs. Part 3, Putting Evaluation Practice into Motion, addresses the useful if it is operationally sound. This pipeline outlines 3 vital steps to operationalize a study. First, practitioners select valid, reliable, culturally appropriate assessment measures. Second, they navigate rigorous legal and ethical imperatives to protect sensitive client data. Finally, they close the loop, communicating findings back to stakeholders and the profession. Sharing results provides the evidence base needed to advocate for policy shifts and sustainable funding. We return to the tension we started with, the perceived conflict between the humanistic art of counseling and the cold mechanics of empirical data. This diagram illustrates the text's central unifying model for resolving this conflict, the accountability bridge. On one side, you have the rigid foundation of scientific research paradigms, statistical methods, and raw outcome data. On the other side is the foundation of empathetic clinical practice, cultural sensitivity, and direct human healing. Program evaluation serves as the load-bearing deck that connects these 2 isolated lands. It allows the science to inform the art, while the art contextualizes the science. Practitioners who embrace research are using data to ensure their clinical intentions translate into measurable relief for their clients. Gathering data provides the objective proof that a counselor's clinical interventions are actually having their intended effect in the real world. This text outlines the technical framework for building that bridge, but its actual utility is determined by the counselor's work